Dr. Olaleko. Olale, I think he's a better teacher than me. So, two of us are cardiologists here in cardio care in Abuja, and we are very happy to share from our knowledge, share from our experience, and different things we have learned over the years, which are very useful here in Nigeria for our care. We'll talk about chest pain today very briefly, and if you have any questions, click on the Q&A box and write your questions there, and we'll get right to it as soon as we are done. Okay, so chest pain and acute coronary syndrome. And we started recording. All the recordings are available on our YouTube channel, so you can go there. Watch not just this topic, you can watch all the Abuja Cardiovascular Symposium lectures, BLS, ACLS, all kinds of things, and really enrich your practice and your patients. We are happy to have you today. So, to say.
I want to say Happy New Year to everybody. This is the first webinar in the year. I think the last time we did it was November. So we welcome everybody, and we are glad that you can take out of your busy schedule to listen to us today. And I hope we'll be able to provide value for the time you're giving us.
Okay, so we'll get right to it. So this lecture is brought to you from the Living Hospital System. Cardio care is in Area 11, Abuja. The other hospitals are Living of Specialty Hospital, which is the innovator brand, and Living Children's Hospital, who say too. Our vision is to empower Africa, Nigeria, and empower people through a healthcare system for training, research, and service delivery. That's why we are here. These are our three hospitals, and we are reaching you from the hospital in the center, Cardio Care. It's a flagship specialty hospital. This is what cardio care we involved in clinical, interventional cardiology, neurology, stroke medicine, ICU care, and all the different things. We put pacemakers, we take care of heart attacks, we do stents, we do surgeries, anything that is complex and requires intense world-class care is cardio care. So today our webinar goals are for one, for you to understand the condition, two, for you to detect the condition correctly and promptly, three, to treat the disease and the causes, four, to prevent complications. So I will want you to understand it in a practical way. So not just the stuff that is taught everywhere, but make sure that you can actually apply it to your
use the knowledge.
Exactly, and use the knowledge in your day-to-day clinical practice. So let's take this first case. Dr. Aleko, I'll read the case and then you will go through it. 24-year-old man, Mr. AJ, insidious chest pain, left-sided, non-radiating, waxing and waning. It is aggravated by body positions and coughing. There are no significant relieving factors. Maybe paracetamol will relieve it. Lasted for hours after onset, is moderate in severity. Similar pain about 2 months ago after an upper respiratory tract infection. No hypertension, diabetes, or high cholesterol. He drinks socially and occasionally takes weed. His blood pressure was a little bit mildly elevated. Pulse was 106. Other things were essentially normal. So, first question: what type of chest pain is this? Is this typical? Is this atypical? Is this non-cardiac? Or you don't know? Can we just type in the chat box? I think everybody has access to the chat box. Can we just type in the chat box
what we think
the answer is? Can we just type in the chat box?
So he has a left-sided chest pain, and positioning, it is worse when he's taking a deep. He had a similar history of chest pain in the past following upper respiratory tract infection. So what do we think this type of pain is? Is it a typical cardiac chest pain? Is it a non-cardiac chest pain? Is it an atypical?
Okay. I think we're having problems getting to, okay, beautiful. think I found it. Sorry, everybody. Now you can comment in the chat box. Sorry, I just realized that you could not comment in the chat box.
Okay,
so good. We started getting the responses. 3, 2, non-cardiac, 2, typical, atypical, Chino. So Dr. Donald said the atypical. Yes, I like this. This is a typical Nigerian vote. Only that we go to INEC and the Supreme Court to sort it out. Okay. Good. So highlight that non-cardiac chest pain does not mean not from the heart. It just means that it's
less likely to be from
cardiac
origin.
Dr. Oliko, can you perhaps just go through this? What is typical and atypical and non-cardiac?
Thank you. We know everybody is scared when it comes to chest pain.
Yeah.
So from the objective we set at the beginning that we want to be able to make an accurate diagnosis promptly and to be able to treat and prevent complications. So the first step in anybody presenting with chest pain, you want to know the type of chest pain the person is having. And there are things that you will see that will make you to think that this is a typical cardiac chest pain, or a less likely cardiac chest pain, or it is not a cardiac pain at all. So what are these criteria? Number one, we want to talk about location.
Yeah.
A typical cardiac chest pain is substernal or retrosternal, or behind the sternum, behind the chest. Most people will talk about left-sided chest pain, not most of the time, but you see somebody pointing to the middle of the chest behind the sternum.
Yeah.
And usually, but we'll know as we go on, usually precipitated by stress, effort, exertion, and gets better with rest or with use of nitroglycerin.
Exactly.
I said as we proceed, we'll see some little, but majorly these three factors. When you have all these three present, you can say this patient has a typical chest pain. If you have less than all three, less likely a cardiac chest pain, an atypical chest pain, or they call it a less likely cardiac.
Yeah.
But if none of this is there,
or just one,
you know this patient has a non-cardiac chest pain. But where I want us to be a bit careful is you can have someone with peptic ulcer disease
with typical
chest pain. So it could coexist,
or you can have somebody with a heart attack presenting with a non-cardiac chest pain. That non-cardiac is just the name. It does not mean it's not from the heart.
Yes.
Warning again. The name non-cardiac chest pain just means that it's just the way we title it. It doesn't mean it's not from the heart. So it may still be a heart attack. It may still be a heart attack. So everybody with chest pain still must have an ECG done. So if we look at this patient again, it is aggravated by body conditions. It is insidious. It lasts for hours. So number one, location. Where is the location? Left-sided. Okay, so 1/3. Number two, what are the aggravating factors? It's not aggravated by exertion, nor is it released by rest. So what we just have here
is just
one factor. So based on this, we will say the answer is non-cardiac
chest pain.
And remember, non-cardiac does not mean that it cannot be anything. It could still be a heart attack. It just means that it is less likely. So look at the location, the aggravating factors, relieving factors, and also we look at associations. Are there any things? Somebody says it's cough due to an exertion. Well, cough is an exertion, but when we say somebody coughed and had chest pain, well, we're talking about exertion like climbing up the staircase, activity, sexual activity, like running, like golf. That's what we mean by exertion. Except you cough for a long time, if you just cough and you have chest pain. That is more like pleurisy or something like that.
Or an infection or something.
So And then we also look at any other things that are associated.
Yes.
Excessive sweating, dizziness,
difficulty with breathing.
Exactly.
Then, if you have other cardiovascular risk factor, then that should also raise your suspicion that you may be dealing with a cardiac chest pain. So maybe the patient has a history of hypertension, diabetes, hyperlipidemia. He had family history of a cardiac attack and is having a chest pain. No matter how non-cardiac it looks, please.
Even if the chest pain is on the right, still do everything.
Do ECG before you say this patient does not have a cardiac chest pain.
Okay, so we'll go on. There are some characteristics that are less likely to be cardiac. It doesn't mean that it's not cardiac, it's just less likely. When it's very sharp and pinpoint, it's less likely. So there's a study that backs this up. I couldn't find the name. When it is just directly under the breast,
yes,
it's less likely. When it lasts just a few seconds, say, doctor, it just comes, it just goes away. Doctor, in fact, the place is just one pinpoint here. Or when you touch that place and that place is tender, you press it and the person feels pain. Or if it is related to posture or when they eat, and especially in patients that don't have any cardiovascular, that is, they don't have diabetes, they don't have hypertension, they don't have history of any cardiovascular disease either in them or in their family, then this chest pain is less likely to be. Can you talk about these pretest risk factors?
So we start talking about this risk factor. So if we go the simple, we say modifiable, non-modifiable, but just to talk about it generally, high blood pressure, high blood sugar, problem with lipid, presence of peripheral arterial disease, people with family history of heart attack or heart disease, especially premature, that is occurring before the age of 40. When you have any or multiple of this in the patient, you know the person has a very high risk probability of developing a cardiac pain. So if you have this in somebody and you found one of the criteria, here now you will not say this patient should go, this is not cardiac. In the presence of all these risk factors, you have to fully investigate that person, not even only stopping at one ECG, because if you do an ECG and that ECG is normal, does not rule out the fact that the patient does not have an heart attack. You may need to repeat that ECG. You may even still have to ask the patient to go for a stress ECG as the case will be. So once you have all these risk factors, then you have to fully investigate your patient before you allow the patient.
So the concept of a pretest is that before you test the person in the algorithm, what is the likelihood? And this is backed up by a probability theory formulated by Bayes, called the Bayes theorem. So before we now say, is it likely or less likely? We now divide the patient. This is high probability, low probability, or intermediate probability for a cardiac disease. So we say it has a high pretest probability if there are two or more risk factors, especially, but if patient has diabetes, it's already high.
Yes.
If patient has previous stroke or heart attack, it's already high. They have peripheral arterial disease, they're having leg pains when they walk, it's already high. Just for those that are joined up, we have over 190, close to 200 people join on this webinar. This is from Cardio Care Hospital here in Abuja. We are teaching on chest pain and acute coronary syndrome. And we're just taking it step by step. We've just talked about trying to classify chest pain and try to do pretest probability. So once people have a high pretest probability, then the likelihood of a cardiac chest pain is very high. And when it's low, we also are not very, very pushy. But in our environment, we see people with no risk factor, and they still have an MI or that. So this is the algorithm formulated by Cardio Care, which for those that were at ACS, you have this in the book that has been given to you. I think we should publish it, Dr. Eleton. That is very We should publish it and make some money. What do you think? All right, so I'm just joking. To wake up those that are sleeping. All right, so if you look at this first and foremost, at the very top, patient has chest pain. So the patient has chest pain. If you are very unsure, you're at home, you're not in a center, please consider referral to a specialist center like cardiac care. And within 10 minutes of reaching the hospital, an ECG must be done. Like we said to everybody at ACS, make sure that you have ECG available within 10 minutes in all your hospitals. It may be your own life that is going to be saved. So within 10 minutes just of ongoing chest pain, it should be done. Then you evaluate the patient at the same time and do a cardiovascular risk profile. That includes history, do an examination, check previous tests the patient may have done, and check blood pressure on both arms. This is important for nurses and for doctors and for others. Please, don't just check blood pressure on one arm if somebody having chest pain. We check on both arms. Whenever we have a significant difference between both arms, typically greater than 20 diastolic or 10 diastolic, we will suspect that that chest pain might be due to an aortic problem. That is the central blood vessel coming from the heart is here, and it's causing chest pain that look like a heart attack. So that we don't, because if you give the same treatment for a heart attack for that one, the patient will die in front of you. So check the blood pressure on both arms in patients coming with a chest pain. Now, the pretest probability which we just talked about, we will come and then do it in this case now and say, are they high, intermediate, or low risk? For those with low risk, we do, and everybody must have an ECG. Remember, if the ECG is normal, then it's less likely, and then you might exclude other cardiac causes. Sometimes, if you are still unsure, add troponin. Troponin is a cardiac enzyme, and you can get it done in most centers, most specialist centers, or you can send the blood to cardiac care immediately. You get your results typically within 15 to 20 minutes, so you can take action immediately. Now, if there's ongoing chest pain or the person having chest pain in the last 10 days, you want to contend to 14 days, you want to do troponin. Troponin will still be elevated up to 14 days after an acute MI. If troponin is negative and ECG was normal, then and the patient even has low risk,
look for other causes.
think for other things. Okay, however, if patient ECG is abnormal, you're not here nor there, please do troponin, and then you can now proceed further. If troponin is positive, admit straight, get to a specialist hospital, and let us manage like cardiac care. Now, if you have one risk factor, hypertension, they have one thing or the other, then you will now begin to consider. First, whether normal or abnormal, please, if they have a risk factor, hyperlipidemia, hypertension, do troponin if you can. If money is not a problem and labs are not a problem, please do a troponin immediately. Then, you now, if you have an abnormal ECG, however, you are also going to do troponin in both of them, and you can go straight to managing in the ICU setting and activating full care. If the person has one or more risk factors and the ECG is normal, please do not send the patient home. Please, severe chest pain, they have one abnormal ECG and the ECG is ongoing. Do not send that patient home. Repeat that ECG in 3 to 6 hours. By the time there is a change in that ECG, consider it as abnormal. If there is a change, ECG is changing, consider it as abnormal. So those are the things. If you send that patient home, that patient may not return back to this world. Okay, fine. Now, if it's a high risk ECG, if it's abnormal, just the same thing like intermediate. However, in high risk, you have a higher index of suspicion. Now, if you have negative troponin with a normal ECG in high or intermediate risk, and the person is having typical or not typical chest pain, you may want to do a stress test. That is, do an ECG on a treadmill using standard protocol. If you don't have a stress ECG machine, you need to refer it to a place that they can do it. You can refer to cardiac care, we'll do it. Typically, you must take certain precautions when you are doing the stress ECG. If stress ECG is positive, go straight to the cath lab, like we have in cardiac care, and then we'll do the coronary angio and then fix any problem. If the ECG is normal, then look for other causes. The stress ECG is normal, look for other causes. Now, if you have chest pain You have a normal ECG that remains normal after 6 hours. Troponin is negative, but the patient has a high probability of coronary artery disease, diabetes, peripheral artery disease, previous cardiovascular disease. Please still consider for a coronary artery. Don't wait until they have a full-fledged heart attack. There's likely something there that may be causing it. Okay, so, and then we'll talk about the management once we get there. I hope this is very clear. I don't know if anybody has any questions on this algorithm. So first, everybody with chest pain, do an ECG. Then, for those with no risk, you may proceed without a troponin if it's normal ECG, but sometimes you should consider doing it. Now, if the ECG is normal or abnormal and there's one or more risk, you must do troponin, and then troponin is positive to an abnormal ECG, then you will proceed further. But I don't have anything to add.
I think essentially it's about the ECG that we should not be confused that, oh, the ECG is normal, because like we'll see as we go forward that you can have MI, heart attack, without a change on the ECG.
Yeah.
Without a change on the ECG, especially I know most of us will be looking for ST segment elevation. You can have it without an ST segment elevation. So, and that is why you need to do your troponin. Make sure you have found whether the patient has high risk. So, high risk patients, normal ECG does not rule out
exactly
an heart attack.
And remember to repeat it. If the patient is having acute ongoing pain, remember to repeat your ECG. Good, and get specialist input. If you are on our Abuja Medical Symposium WhatsApp group, and we'll give you an opportunity to join the WhatsApp group during the course of this presentation, you can send your ECG there so that we can all look at it and assist you. And you can reach out to us in cardio care. We can assist you and give you guidance where necessary. All right. So now this ECG, can you go through so that they can know what is?
So we're talking about changes on ECG. So what are the changes we're looking at? The changes we're looking at is we're looking at the ST segment, which is the line joining the T and the S wave. Though the S wave is not showing
the QRS complex
in, yeah, so, but here we can say the QRS complex. The S wave, like we teach in ECG, is your second negative deflection or the negative deflection after the first major positive deflection on ECG. So there is this line joining that S wave or the QRS complex and this T wave, which is called the ST segment. So the ST segment is supposed to be on this straight line. So if you draw a straight line from this T wave to the P wave, the ST segment should be on that line.
Yeah.
So when we are saying the ST segment is elevated, that means this line is above this straight line. So if you follow my cursor and you look at this, so this is the line that I talked about. So we can see that this ST segment that joins this T wave and this QRS complex is above this line. So we'll say that if you are looking at this line, if there's elevation greater than 2 millimeters in what we call contiguous leads, I believe those people that have been joining us for ACS will understand, and for some of our past webinars where we talk about ECG, we understand what we mean by contiguous lead. We are saying the leads that are looking at the heart from the same direction. So we talk about lead 2, 3 AVF looking at the heart from below, inferior leads. Then we talk of lead V5, V6, 1, and AVF that is, they are looking at the heart from the lateral aspect. Then we talk about V1, V2, V3, V4, looking at the heart anteriorly and around the septa. So we call it anterosepta. So when you are looking, so at least 2, where you have 3, must be saying the same thing before you say there is a significant ST segment elevation, or sometimes you can have it depressed below that line. So you can also have ST segment depression. So I think that's just the summary of what we're looking at, and also the shape of the elevation. because both are important when we are talking about chest pain. For myocardial infarction, for heart attack, the ST segment is what we call convex, or what we call concave down. So the person is frowning. While for other cause of chest pain, what you have is a concave ST segment elevation. That is concave up. That is the person is smiling. So when somebody is frowning, you see the way the lip is going to be. That is what we see in patient that has heart attack. But in patient that have like pericarditis, due to inflammation of the covering of the heart, you can have this other pattern where you have this concavity. But other things that will help you here is, for pericarditis, you will have it diffuse. It is not a contiguous lead as you have in patients with heart attack.
Let me just add that I thank you all for joining us. We have over 240 people joining us today, healthcare professionals from across the country. This is cardio care, and we are teaching about how to manage chest pain. We first started by explaining the types of chest pain, and we said the chest pain could be typical, atypical, or non-cardiac, depending on the location and whether how it responds with exaction or duration. We now see that every single patient that presents with chest pain, including ulcer, should have an ECG. No exceptions. Every single patient. We now see that the ECG could show you a problem with the ECG or not. Now we say this is a normal ECG. We typically look at the ST and the T wave, and it's normal because on the line, the line is straight. So this line and this line are on the same level. That is why we say that it is a normal ECG. When this line has this QRS complex that looks like jaga, up, down, up. When this line goes up like this, we say that is an ST elevation MI. When it goes down, or there's a T wave upside down, T wave is upside down like this, we say there is a T wave inversion. Okay, in that case, if you find any of these three abnormalities, that ECG is abnormal. So when we talked about our algorithm for chest pain, and we're saying normal or abnormal, whenever you find any changes in the ST segment or the T wave that is upside down, that ECG is abnormal. Now it is further strengthened when there is more than one lead that is showing it, and preferably the leads that are grouped together like this. You need to cram these leads, preferably the leads that are grouped together like this. So if you look at that, you can now see what we're talking about. So we say normal, abnormal. So this abnormal, all abnormal ECGs must have a troponin. Now you are reaching us. We have over 260 people. Yes, 250 people now. You are reaching us from far and wide. You are saying, in this part of the country, we don't have ECG. What do we do? Nothing. Go and get ECG. Oh, in this part of the country, we don't have troponin. What do we do? Nothing. Go troponin. Nigeria is not broke. Go and get it. It is critical. It is critical to be able to differentiate the heart attack from not a heart attack chest pain. We have blamed witches and wizards, and that the person, it was time for the person to finally make it. Then he was about to become a director, then somebody killed him. Nobody killed him. He had a chest pain and an MI that killed him. And that's what we are trying to teach. As soon as you do the ECG, check this line of the ECG. Check the ST segment that we pointed here and the T wave. If this is up or below this line, then we say that is an abnormal ECG. And preferably, if it now further comes together in similar leads that are looking at the same part of the heart, we say, this person is likely having a heart attack. If you don't have cardiac enzymes like troponin, but you have ECG, it may be enough if the ECG is very clear. But when the ECG is not clear, like in NSTEMI, you absolutely need that enzyme to be able to help you. So that is what we've just tried to discuss here. So there are some history that may help you if it's worse on lying down. And when you lean forward, like I'm leaning forward now, it gets better. It's more likely to be due to pericarditis. Now, I must make a caveat here. Pericarditis can happen after an MI. Yes. I could complicate an MI. So it will show that there's a complication. So it does not mean like, say, this is a pericarditis, take it and go home. No. you must still follow the algorithm that we have set before you. This algorithm, it will take a long time for you to be able to master it, but it has been put together from years of experience here in this country. So if there's dyspepsia, that is, it is worse when they are hungry, and it gets better when they eat, and it is peppery and it's burning. It's unlikely.
And we should also still be careful with this, because if you remember, Christmas Eve last year, there's a man that came in that has been managed repeatedly for peptic ulcer disease, and when he came in on that on the 24th, my birthday, that's why I didn't forget. He has ST segment elevation from V1 to V6. Elevated troponin, and it was the one that we did plot extraction.
Yes, I will show you the case. I will show you the case before.
So please, we are the fact that chest pain improves with use of antacid and whatever does not rule out
at all.
So you can have an ulcer and at the same time have an heart attack. Please, any adult with chest pain, please do an ECG.
Please, even if you say ulcer, if you have an adult with ulcer, please do an ECG. It is cheap, it is available, it is non-invasive, it doesn't hurt anybody to have an ECG. All of us, 252 now, people on this group, on this call now, across the country, go and do your own ECG. Have a baseline ECG that people can use. God forbid there is a problem. Have an ECG, just like you have your passport. Post it on Instagram and keep it there. And thank God, cardiac care. I'm joking. Okay, fine. I think this section could be discussed. These are just pointers. It does not mean that you will sit and we can have polluting chest pain and have an MI. It does not stop anything. You could have fever and have an MI. So you will still do ECG, but when you're taking history, look out for this, which will be a pointer, so that you don't miss the diagnosis. I'll just keep this.
Okay, still that's
this same case. Okay, fine. So that same case, 24-year-old man, AJ. AJ has come with insidious left-sided chest pain. It is not radiating. It is waxing and waning. It's aggravated by different body positions and coughing. There is no significant relieving factor. It has lasted for hours after onset, moderate. He had a chest pain similarly like 2 months after a respiratory tract infection. No significant risk factors. He drinks occasionally and smokes weed. Blood pressure was 146/76. Pulse was elevated. Other things were normal. So, question 1, is the history and clinical examination adequate? Yes, no, I don't know. Can we put in the chat box? Yes, no, I don't know. Yes, no, I don't know. Put in the chat box. No, no. If you say no, tell us what is missing. If you say, I can see some people say yes. If you say no, tell us what is missing. If you say I don't know, be bold, right? I don't know. Thank you, Onoge, Gabriel Uma, Olashino, Abiola, Hadiza Shetima, Judith Agbo, Mildred Alexander, thank you. Yes, I don't know. These are ECG. I don't know. No, but just ask about the history and clinical examination. So there are some things that we want to know in this history. One of the things we talked about is previous family history of sudden cardiac death, of cardiac attacks, previous history of cardiovascular disease, strokes, and the like are also important. Okay, so some of those histories are also important in this case. So we'll go forward. This is the ECG of the patient. What do we think? Is this normal, abnormal, or I don't know? So we have gone to the ECG. Normal, abnormal, I don't know.
This is a part of the presentation that people don't like to see. But
so, by the way, if you go to our YouTube channel, Cardio Care, just search your Cardio Care YouTube channel, you will see several presentations where we have taken time to explain ECG as simply as possible. So if you follow them, you will be able to do an ECG. Okay, and we are coming up with a very nice course that anybody can do on their own time and get a certificate for. Okay, so let's go through it out together. I can see different answers there. Normal, abnormal, normal, abnormal, normal, abnormal. Okay, so people say abnormal, they not tell us what was abnormal. Okay, so let's look at it together. we look at the ST segments. So in all the ST segments, we cannot see any elevation or depression.
Yes.
However, we can see that the T wave is inverted here in 1, and then the brother of 1 is what? AVL and V5 and V6. So we can see the T wave inverted in 1, is inverted in AVL, and it is somewhat inverted in V2 and V3, but V2 and V3 are not brothers. But we can see 1 and AVL. We have over 260 people joining us. Thank you for joining us today from Cardio Care Abuja. We are leaders in cardiovascular medicine, National Center of Excellence. All right, so we'll proceed. We did this investigation. ESR was 30, white blood cell count was fair, cholesterol was marginally elevated, LDL was not bad, and these were found. Troponin was normal, and stress was negative. So what is our final diagnosis? White blood cell count 6,400, platelets 220,000. The other things neither here nor there. Troponin normal, stress ECG negative. What is our final diagnosis? Final diagnosis. Yes, final diagnosis. Dr. What do you think?
So from this, it's clear that it's not
an
MI. Pneumonia is less likely.
It's less likely because the
pulmonary embolism
is
less likely. So the most likely answer here is musculoskeletal pain. But like you said, there's still some T-wave changes, some left axis deviation, so there may still be need for further evaluation. But if you look at this, the most likely from this option is likely a musculoskeletal chest pain.
Now remember very well that if a patient comes in and has ongoing chest pain and has that kind of ECG, repeat it in 3 to 6 hours before you make any final change. Why is it unlikely to be MI? Why is it unlikely to be acute coronary syndrome or MI? So acute coronary syndrome, and help us go through this.
So now, talking about acute coronary syndrome is a spectrum of clinical condition. Where patients has recent changes in symptoms,
correct,
with or without changes on the ECG, and with or without elevation of cardiac troponin. And so that's why we kept repeating that the fact that ECG is normal does not rule out the fact that patients cannot have acute coronary syndrome, which we said is a spectrum of 3 conditions. So, and the 3 conditions are unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction, or we can say there is MI with normal troponin, MI with elevated troponin.
Well, when you say MI
or let's ACS with acute coronary syndrome with normal troponin, acute coronary syndrome with elevated troponin. Let's put it down.
If the enzymes are elevated, it could either be N-semi or semi elevated enzyme. If the ECG is not showing a classic ST elevation, it could either be unstable angina or N-semi. In unstable angina, the enzyme is negative and the ECG is negative. But it's not completely negative. It has some T-wave inversion, it has some ST depressions, sometimes. Now, if the enzymes are positive and the ECG is not a classical one, typically we'll now say you have an N-semi. So N-semi typically, like I put the star here, typically shows other signs of myocardial ischemia with positive. Now, in a third case, the ECG is showing query elevation and the enzymes are negative. You need to now consider, one, are you catching the MI too early?
Too early, yes.
So things are happening. 2, is there an old MI that the ST elevation has failed to come down? 3, are you dealing with pericarditis, in which case there is widespread ST elevation and then some elevated enzymes or not. So this is what kind of tries to help us. So negative ECG, negative enzymes, unstable angina. All of these people have chest pain ongoing. Then they have negative ECG, But ECG has ischemic changes, and positive enzyme STEMI. Positive ECG, that is ST elevation, and positive enzymes STEMI. All of these are classified like this because of prognosis. Number 3 has the worst prognosis and going down like that. This is why you have to really take them up. Anybody with an MI, you has to get intensive specialist care immediately. Again, intensive specialist care immediately. Do not joke with an MI. They can be laughing with you one moment and dead the next. So don't think that the patient was stable. I find the patient walking to the hospital. There is nothing like that. Once you make the diagnosis, that patient can be laughing with you 1 minute and is dead the next. Do not take it lightly. So one of the very main reasons we are here is that people say, oh, he just had an ulcer now. This ulcer has been there for 1 week. Please and please, you have attended this webinar, and this webinar will stand against you. All right, I'm joking. All right, fine. So can you take us through this universal definition, sir?
So the universal definition is just re-emphasizing what we have talked about. That what defines myocardial infarction is you must have evidence of injury to the myocardium, correct? Plus symptoms of myocardial ischemia, correct? So the pain and all those stuff we talk about are symptoms of myocardial ischemia, correct? But if you don't have evidence of myocardial injury or necrosis, which is elevated troponin,
exactly.
So if you have evidence of myocardial ischemia, which is mainly chest pain, or maybe you did your echo, you saw some changes, as in mainly symptoms, you will say the patient has unstable angina.
Exactly.
But once you have evidence of cardiomyocyte necrosis or injury, which could either be troponin,
yeah,
you did your echo, you saw hypokinesia or whatever, or any other evidence of reduced mobility or abnormal mobility, or you did, if you have CT angio or all those stuff. Once you have evidence of injury to the myocyte and with ischemia, the patient has a myocardial infarction. Now you now look at your ECG. Is there an elevation of the ST segment? Then it becomes STEMI.
Exactly.
No ST segment elevation, non-STEMI. So that is what this one is telling us.
All right, I'm sure we are getting from this. Chest pain nugget number 1. Everyone, every single person, whether it's your priest, whether it is your imam, your friend, your father, anybody coming with acute chest pain must have an ECG within 5 to 10 minutes of entering the emergency room. Everyone, and that should be interpreted. Everyone. This is a standard. This is a standard. So I know we are not doing so many standards and litigation in Nigeria, but this is a standard. Everybody must have this interpreted so that we can. So let's take this second case, Dr. Harrison.
So we have a 56-year-old male here with worsening sharp, with emphasis on the word sharp chest pain in the last 2 days, aggravated by coughing and when he's lying supine, and it gets better when he sits up. It radiates to the left arm and back. There's associated fever, tachypnea, nausea. Is a non-hypertensive. Previous history of stroke with residual weakness, and he has tachycardia, the blood pressure 146/76, tachypnea, and the oxygen saturation was 88% in room air. Rushed into our emergency, and the chest exam is normal. No smoking, no issue of alcohol consumption.
Beautiful, beautiful. So again, can we answer in our chat box? Typical chest pain, atypical chest pain, non-cardiac chest pain? I don't know. Can we please answer? We have close 260 plus people that have joined this webinar today. Is this typical? Is this atypical? Is this non-cardiac? Remember, we said that typical chest pain has, well, should I keep saying it? Let them try. So somebody say typical, atypical, and then we say atypical has whatever. Good. Ebuka Ekozo. Gabriel Umar, thank you for trying. Christy Wonu, thank you for trying. Okay, Ngoka, thank you for trying. Yes, a typical non-cardiac Chinonso. Thank you all. Abdulazak Abdusalam. I see you. Ansler Abdulusi. Okay, good. Everybody is saying typical, atypical, typical, atypical. This has to go to Supreme Court. So let's go to Supreme Court and see. We defined typical and atypical by number one. We said if there's chest pain in the typical retrosternal or left-sided, that's 1/3. 2/3, it is aggravated by exertion or emotional stress. And 3, it is relieved by rest. This is not relieved by rest, it's relieved by sitting up. This is also not aggravated by exertion. The person just coughed and had it, and it's aggravated by lying flat. So,
and we also talked about some other features that make chest pain less likely cardiac.
Correct.
And one of the things we talked about is the pain being sharp,
very sharp,
and of very long duration.
In fact, a lot of patients with chest heaviness, not pain, and yes. So we must be very,
so
very
it's
cautious.
Described as discomforts, heaviness, load on my chest. So by the time somebody is describing a very sharp pain, it is less likely. But we have warned us that we should not just be swayed by all this description.
Go and get evidence for the Supreme Court. So now we now came here, and then so this is an atypical cardiac chest pain. Okay, it's atypical more or less. All right. So ESR came out as 90. Troponin is normal, also normal from the referral center. Full blood count has a slightly upper limit of this total white cell count. EU was otherwise. Fasting blood sugar was impaired. HbA1c2 was slightly impaired. Urinalysis was normal. This was ECG. Is this a normal or an abnormal ECG? Yes, remember our algorithm? Normal or abnormal? Can we please put in the chat box? Normal or abnormal? Somebody say, will the slide be shared? Yes, the slides will be shared immediately after this, together with CME points. If you join for 2 minutes and left, you will not get the CME points, so don't be angry. But if you have to join for a significant period of time to get the CME points so that you do the right thing, good. So use the chat box and answer. Use the chat box and answer. Abnormal, 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 normal, ECG abnormal. So fine, let's look at it together. See the line here, and see this ST segment. Is it elevated or not? It is elevated. Let me see. So can we see that this line now, it is elevated? We can see that it's elevated in that area. It is also elevated here in V2. It is V3 is elevated. V4 is elevated. See the lower line and see the upper line. It's elevated there. V5, V6 is elevated. Okay? Even this AVF is slightly elevated. The V2 is elevated. Almost everywhere is elevated. So that is a major problem that we have seen. It is elevated in multiple places. So you can see the elevation here, 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 here. And then we say the troponin was normal. So what would be the diagnosis in this case? What would be the diagnosis in this case? What will be the diagnosis in this case?
We talk about that ST elevation
almost
everywhere,
and
troponin is normal. The chest pain is relieved when the patient tried to sit up.
Correct.
There was fever. The WBC upper border of normal. So in this condition, what would be our most likely final diagnosis? So
somebody says acute MI, while other person acute MI, most people are saying pericarditis. Good, it's working. It's working.
So
it's working.
I think we're in the right direction. So this is likely.
So let's look at it again so that we can just remember. We can see the elevation, what elevation and depression is from here. And then we said positive ECG sub-elevation widespread with negative enzymes. You should consider pericarditis. Once the enzyme is negative, it's more likely. And then this chest pain has that typical lying down, worsening, and sitting up in the legs. And then the ST elevation is widespread. So acute pericarditis. I'm so happy. Woo! Great. We're making progress. Okay, so based on the result, acute pericarditis was made with cath lab step down, admitted for bed rest, had antibiotics and anti-inflammatory agents. By day 4, less breathless, he did not need oxygen again, ASR reduced, white blood cell count also reduced. And this is the repeat ECG after treatment. And you can see everything has come down. By the way, there are 4 ECG stages for acute pericarditis. Yes. So in this case, what are the clues? The chest pain was retrosternal, it was pleuritic, it was positional, there was widespread elevation and PR depression, and there was minimal or normal, minimal cardiac enzyme. So remember, pericarditis could be a late complication of STEMI, so keep your eyes open. This could just complicate an MI that person have had before. So keep your eyes open. These are the 4 stages. First, widespread ST elevation. So when this man came in with breathlessness, with SpO2 low, he was in stage 1, widespread and reciprocal changes. Okay, next we start normalizing. The T wave starts flattening within 1 to 3 weeks. Next, the flattening T wave become inverted, and then stage 4, the ECG returns back to normal. So this is the typical ECG stages. It doesn't always follow like this. Less than 50% of patients progress classically through this 4. Some could jump from 1 to 4, and so on and so forth. So just for you to know this. Okay. So somebody asked before that how do we differentiate benign repolarization? I can see that in the Q&A. Sandra Ogwanochi Chiakwelu, sorry. So ask that how do you differentiate STEMI and any repolarization phenomenon? I get a bit confused. So let's unconfuse you. Number 1 way to help is to look at the ST to T wave ratio. ST to T wave ratio. Okay, so we look at the ST segment elevation versus the height of the T wave. So let's assume this ST segment elevation versus this height. So this ST segment elevation, for example, is call it about 3 small boxes, and then the height of the T wave, call it about 10 small boxes. So call it 10, 11 small boxes. So if it is greater than 0.25, you are thinking of pericarditis. While it is less than 0.25, you are thinking of benign early repolarization. Okay. Benign early repolarization is more common also in V2 and V3, and it's not typically in contiguous leads. Then the fish hook pattern, typically in V4, you can see how it is here. Fish hook, just after you just have a small hook there. Typically will move towards early repolarization, and then the ECG remains stable in benign. Unlike this one, the ECG is going up, after a while it comes down, normalizing T wave events. This one remains stable over time.
And the age where this is found.
So good.
This is common in young, early middle age people. You rarely find that picture in elderly patients. Then, like we said, when you look at your ECG, you couple it with your clinical presentation for you to be able to determine what you are dealing with.
Okay, so if you have questions, put them in the chat box. We're talking about chest pain. We are going on. Must ECG be done for all patients presenting with abdominal pain who also has precursor factors? Victor Ajiboye asks, the answer is yes. Yes. ECG should be done for all patients, even if they present abdominal pain, especially if they have a diabetic comes abdominal pain, do an ECG. Please do an ECG so you don't miss and embarrass, because the cost of missing it is too high. It's typically death. So you cannot afford that. Okay?
And we should not forget, in women, people with diabetes, what they have is what we call angina equivalent. They may not present with chest pain. It might just be dizziness. It might just be undue tiredness. So please, The cost of ECG, like we said, is far, far cheaper. And if you have ever lost any patients to this because you are thinking it was peptic ulcer, you will not mind doing ECG. I used to tell my patient that if you come in every day complaining of chest pain, you will do ECG every day. Because the fact that the ECG was normal yesterday does not mean that it will be normal today. So please, let's have that at the back of our mind.
Okay, we have over 260, close to 270 people that have joined us from around the country. This cardio care or special clinic in Abuja, where the National Center of Excellence for Cardiovascular Medicine, private. We hope to reverse medical tourism. We do that with our cath lab, with our cardiologists, our specialists treating all manners of cardiovascular disease. But also we want to educate and grow the Nigerian medical populace to improve healthcare. And so today we brought chest pain to you, and we are going for it. If you are just joining us, at the end of this lecture, you will get in your emails, the email you to register, you will get your CME, and you will get a copy of the slides. You will get that within 3 to 5 days after this lecture. You can also rewatch the lecture on our YouTube channel and other lectures that are there. This is for those that are just joining us. Chest pain nugget number 2, cardiac enzymes are invaluable. A negative troponin in an appropriate patient should be repeated. So troponins typically start rising from 6 to 12 hours. So the patient is having chest pain right now that started 1 hour ago. The ECG may be showing elevation, but the troponin is negative. Does not mean repeat the troponin in 6 to 12 hours. You will see that it started rising. So you should also be considerate that sometimes it can lag behind. And we have gone through this algorithm before. We want to do all patients ECG, then abnormal or normal ECG, do troponins, and then if you have intermediate pretest, you should consider doing a stress ECG, which can do in cardio care. If you are not sure, please refer to a specialist or call us in cardio care. You can refer them to us. Case 3, I remember this case. The daughter of somebody in our choir, 16-year-old female, central chest discomfort, outpatient referral, easy fatigability, very minor chest discomfort over the last 2 weeks. Anytime she walks for some distance is aggravated and is relieved by rest. No radiation, associated lethargy and malaise. Because she's a young girl, 16 years old, no hypertension, no DM, no smoking, alcohol, no illicit drugs. She's tachycardic. Pulse rate is 110, blood pressure is normal, very mild ankle swelling, as if it's almost having heart failure. And oxygen saturation is normal, chest exam is normal. This is looking difficult. This is looking difficult. This is why we are here. Okay, so let's go. Troponin came out, CD troponin, 9.7. That is maybe over 20 times, over 30 times the upper limit of normal. White blood cell count slightly on the upper side. All other things are within normal. Fasting blood sugar slightly. ESR 80, very high. HbA1c and blood sugar is relatively okay. So this was the ECG. Is this ECG normal or abnormal? Or let's go this way. Is this a myocardial infarction? Yes. No. I don't know. Is this a myocardial infarction? Use the chat box. Don't use the Q&A. Use Q&A to ask questions. Is this a myocardial infarction? Yes. No. I don't know. Again, let me show you the ECG in case you missed the ECG. Maybe you blinked. This is the ECG. Yes. No. I don't know. This was the ECG. And we said the troponin was over 30 times the upper limit. ESR was also severely elevated. This person is a 16-year-old. Is this with no risk factors, no pretest, low pretest probability? Yes, try. Better to be wrong here and to be wrong on the patient. All right, great. So a lot of people, no, yes. Somebody said no, angina pectoris. Okay, let me just say, this is showing now. Let me just say, angina pectoris is not a diagnosis. Angina pectoris is not a diagnosis. Let me say it again. Angina pectoris, well, not like that. But angina pectoris is not a diagnosis. It is like saying chest pain.
Yes.
Angina is another name for chest pain. Pectoris is chest, angina is pain, more or less. When we say a woman has angina, is pain. So we have this. So let's look at the ECG. Is it abnormal? In most cases, it is almost normal. Hardly any ST elevation or depression. But there's still wave inversion here from V3, V4, V5, V6. So slightly abnormal, but no significant ST or T wave changes. Okay. So it is possible that it's an SMI because the ST, there's an abnormality on the ECG.
So could it be a myocardial infarction?
Yes.
It could be the one without ST segment elevation.
Correct. So now before you now proceed, you need to now go and check. Okay, remember this thing by the ESC. We have elevated cardiac enzymes. You need to ask yourself, is there acute ischemia
or not?
No acute ischemia. So we now look at this case. Is there acute ongoing chest pain? The answer is no. He had just mild, more or less was breathlessness when she walks. So there is no acute ischemia, and in that case, you are dealing with either myocarditis or a heart failure. So you have elevated troponin, and you have myocarditis or a heart failure. Now, if you check over time and the troponin remains stable, it's not going up and down, then you think of a chronic myocardial injury. Okay, so in this case, no significant chest pain over the last 2 weeks. I'm going to school, just get a little bit breathless, some leg swelling here and there, and ESR is elevated. So we think it's more of a myocarditis that gave us that chest pain.
I remember the lady went as far as
America.
UK.
Yes, went to the US
and came back with what we give to them.
The same diagnosis was myocarditis after they spent some very thousands of dollars. So that's what yes, like,
and it's also to show us that troponin elevation is not only caused by
that is why the definition was very key. There must be evidence of acute ischemia, like chest pain. So in this case, there was no chest pain, just the troponin was elevated. That's all. And then we had all those other symptoms. So that is what it looked like. So let's take this case. 65-year-old man, pressure like chest pain, 12 hours ago and 2 hours, aggravated by walking, relieved by omeprazole and relieved by rest. Associated dizziness, palpitations, and weakness. Doesn't have hypertension, but blood pressure was elevated at the source of referral. He was given amlodipine and temozoltan. He had to even have 2 drugs for when he was referred, and he was given omeprazole. Doesn't smoke or drink. He was referred to cardio care from another hospital as an emergency. Pulse and blood pressure was this. Respiratory was 30, so he was tachypneic, and the SpO2 was low. So, what do we think? What kind of chest pain is this? So let's put in the chat box, what kind of chest pain is this?
So let's consider the location is brought on by exertion, released with rest, and omeprazole. Not previously hypertensive, but had to be given 2 blood pressure medication to bring the BP down.
Yeah.
Look at the age.
Yeah. SpO2, all of that. All right, atypical, typical, but more typical. So this is more typical, right? Number 1, it is retrosternal. That is first, so 1/3. Number 2 is aggravated by exertion, walking, 2/3. Number 3, it is relieved by rest, 3/3. So typical chest pain. Typical chest pain. And we also talked about related risk factors. BP was elevated, related problems. He had dizziness, he had palpitation, he had weakness, SpO2 slow. So typical chest pain. You should be very careful with this case. Now, guess what? See the troponin over 40 times the upper limit. H. pylori is also positive. That is why don't just go and start doing H. pylori. It does not solve any problem. In fact, after you treat it, it will still remain positive for a very long time. So cholesterol is elevated, ESR was, HbA1c was mildly elevated, and that's what we found. But troponin is elevated. So what's the next thing we look at the ECG? So let's see the ECG. Now look at the ECG. Is this ECG normal or abnormal? So that we don't waste time. Or what's the final diagnosis? What's the final diagnosis for this case? Let's just write on the final diagnosis for this case. Let me go back to the ECG so that you can see. What's the final diagnosis for this case? Wow, people are getting it. Acute STEMI, that is it. It's not just MI, it is STEMI. There's ST elevation, it's not non-ST. We can see V2, V3, V4 all showing elevation. Although the ST elevation is on the downward trend, it's already coming back down. But this is classical concave upward elevation. Anti-wave inversion. Somebody says anti-receptor, that's a good person. Clement. Well, sorry if I don't know that it's professor or so please I apologize. Samuel Eja says and acute STEMI. So great, thank you so much. So we think yes, it's an MI in this regard. We have ongoing signs of elevated troponin. We have acute ischemia, acute MI, and then we know we have taken it. So how is MI recognized? We have 4 profiles. 1, chest pain, most common. 2, complications. People may just come with complications, heart failure. 3, they may come and they may have no other symptoms, just a silent MI. And 4, sudden cardiac death, just cardiac arrest. But remember, not everyone with heart attack has chest pain. Please, they could have abdominal pain. We have done the angios for people with abdominal pain, no single chest pain, and it was an MI, and we had to put a stent, emergency. Luckily, the person that referred the person had been for one of the presentations and was able to diagnose. Let's do an ECG, and they just saw it. Bam, they brought the patient immediately, took the patient in and stented the patient's artery. So, and those are the 4 typical profiles. But patients could also have tachycardia, hypertension. We are moving a little bit faster. We've gone through all of these things. I will not move about this. So, Dr. Can you go over this?
So, acute coronary syndrome. So they say it's as simple as ACS.
Oh.
So we talk about your abnormal ECG, whether it's ST elevation, ST depression, T wave inversion, or you have your Q wave. Then the clinical context, history of chest pain, history of hypertension, all the risk factor. Then you want to know, is this patient stable? Because we said the patient can come with chest pain, or can come with complication, either heart failure, can come in shock, can come with arrhythmia, or can even come in coma. And this will help you to quickly make your decision as per what's the next step to do. What am I going to do for this patient? Am I supposed to rush this patient to a place where angio can be done? Or if I can't get there within a good time, can I give a clot blocker for this patient as soon as possible? So this will help you to make that initial assessment so that you can quickly, because like we talk in the neurologists and neurosurgeons talk about time, brain cell is time.
Time is muscle.
So time is muscle. The longer you wait, the more cardiac muscle that you lose.
Okay, so how do we treat myocardial infarction? So what will you do? You have made the diagnosis. What will you do to treat myocardial infarction? So first of all, early response is critical. Early response is absolutely vital. Within 1 hour, you have, little, if you can abort less than 1 hour, little damage. 1 to 2 hours, minor damage. 2 to 4 hours is already moderate. By the time you are getting to 6 to 12 hours, you are beginning to have permanent loss. Greater than 12 hours, sometimes you don't even bother reperfusing, except the patient is hemodynamically unstable or So we have, can you go over this, Dr. Olalekan?
So like we said, that time is muscle. So what you want to do is to restore blood flow back to that heart muscle as soon as possible. So that is your number 1 goal. So no matter the means you want to use, you want to restore coronary blood flow, you want to reduce complication, and when it has set in, you want to treat it. You want to reduce mortality and morbidity, prevent recurrence, and you try to rehabilitate this patient, because some of them, by the time they come in, they've already suffered significant loss of cardiac myocytes, and the cardiac function is compromised, and you may need to do some form of rehabilitation. But that's number 1. Is very, very essential
as possible. If you are in Abuja environs, you can send to cardiac care. We have a cath lab, and we have a team on ground that can get the patient in and open up the blocked artery immediately. That is the gold standard. If you are farther away, you need to consider giving a thrombolytic, something that can block, that can open that blood clot, and then you can now transfer for us to now put a stent in to open. And if you cannot do any of this, or there is severe financial constraints, you may now consider other things. But you must treat them very, so reduce complications, treat any complications, reduce mortality, reduce risk of recurrence, and rehabilitate. This is critical to patient survival in this case. So first of all, immediate log ECG, like we said before, and then make the diagnosis. If you make the diagnosis of MI, start ECG monitoring immediately, IV cannula immediately. You should have ongoing ECG monitoring. You put a monitor there where you are seeing it, because you can have a reading that will stop that patient's heart. You can go and watch our talk on ACLS so that you can pick a reading that can kill that patient. You can see it on the screen. So pain relief, do your blood test, give aspirin 300 milligrams starts unless it is contraindicated. Now, peptic ulcer is not contraindication to aspirin when it comes to MI, because the MI will kill the patient first. So give them, you can give them something else later, but give them, they should chew it, not swallow. 300, and then get specialist input as soon as possible. These are the numbers of cardio care if you need transfer the patient urgently to the hospital. So, and that's what you need to do. Now, for all the patients, medical management, you give pain relief, give oxygen if the SpO2 is low. So pour NAS somehow or something. Oxygen, then give nitrates for, you have to get caveats, you talk about that. Give antiplatelets, give high dose statin. Typically give 80 milligrams of atorvastatin or 40 of rosuvastatin. Anticoagulate, beta blockers, and ICU care. Please do not compromise. It doesn't matter how stable the patient is looking. I beg of you. I am kneeling down in my heart. I beg of you, please. Then get them to a cath lab as soon as possible. Urgent PCI. If you cannot get to a cath lab within 2 hours, then start thrombolysis with one of these agents and then get it to cath lab thereafter. If you could not do that within 12 hours of the patient having chest pain, 6 to 12 hours, then do medical management, stabilize first, and then send to a specialist, send us, and then follow up, treat all the complications. So this is just a very simple way. So morphine for pain, oxygen where necessary, nitrate, but don't give nitrate if it is the X elevation is in the 2, 3, and ABF. Don't give nitrate if the patient has taken Viagra recently. So ask.
In the last 48 hours, 24 hours.
Ask. Some people took something and they were on top of woman when it happened, and then you just did. Ask so that you don't kill the patient on your table. So ask. Don't be ashamed. Send everybody else if you need to. Then aspirin plus clopidogrel typically. 300 milligrams typically of aspirin chewed, and then you could take clopidogrel 300. High dose statin, and then heparin or clexane for anticoagulation could be given. Okay, now there are other things, A, B, C. A for ARB, if there's no hypertension, B for beta blockers, and C for CCU admission and specialist care. This is how you manage. This care must be given by everybody. Wherever you are, you can give this care, you can save that life. Wherever you are, you can save that life after you make the diagnosis of an MI, of acute coronary syndrome. So get specialist care as early as you can. MI kills. It kills. Please and please. So PU, I've given all the details here. Nitroglycerin, you could do sublingual, clopidogrel, typically 300 to 600.
You have nitroglycerin spray.
Yes.
You can also do that.
Yes, under the tongue, you just spray it there. But don't spray more than 3 times in 1 hour. Don't spray more than 3 times in 1 hour. Don't give more than 3 times under the tongue of the tablet in 1 hour. Please, please, please. You could have very intractable hypertension. Then beta blockers except contraindicated, and then high dose statin. So these are the doses you want to give them. Okay, so patient has come in early. We try and get to the cath lab as soon as possible. Get straight to the, and luckily cardio care is here for most of northern Nigeria, most of the country. We can get the patient here and we can take care of the patient as soon as we get in to the hospital.
And the goal is to be able to do that possibly within 1.5 hours.
Okay.
Not more than 2 hours if
Exactly.
it is possible.
So I will just try and show you what the angio looks like. Let me see. What this thing looks like. What they're doing. Okay, so that is Cardio Care Hospital, and that's us here. I'm just showing you what the International World Class Hospital looks like. So this is what the cath lab looks like. The entire team is always on standby. These are different people coming in where we are showing how to do it. We just take a puncture first in the femoral artery, and then we pass a wire in and a sheet in. So a very simple procedure. Then we now get a catheter through. The patient is typically awake. We pass a catheter through the femoral artery up the ascending aorta and into the coronary vessels. Takes less than 5 minutes or 2 minutes to be there, and then we can see where the blockage is. We do on the right and we do on the left. Sometimes we use the radial artery, not just that. And for example, in this case, we can see this blockage right here. So what do we do when we see a blockage like this patient's MI? We take a wire, like we have seen the wire, and pass it into the coronary artery. So you can see how we are passing the wire in. The wire goes ahead, then we put a balloon to open it up first. Then after the balloon, the next thing, a blow. The next thing, we put a stent. The stent now keeps the place open, and blood vessel and blood can now go, and the blockage is gone. So this is what we do routinely every day. I'm sure doesn't have to go abroad. This is what we use to inflate the balloon of the stent. It's not just a syringe. It's a special device that we measure the pressure that we are putting in. So when we are doing it, you can see that blockage that was there before. You can see us inflating the balloon there. And then after we have done all of that and put it, you can see that place that was blocked now is completely opened up. Chest pain will disappear, patient is fine, and then patient can move. Sometimes we have to give drugs directly into the coronary vessel. Drugs like adenosine, drugs like nitroglycerin, but that is very high specialist care. Okay, so that's what happened. It's typically a very, very simple procedure, and it takes about 30 to 60 minutes, and appropriate thing. So that patient we talked about, he had the coronary angio, 85 to 90% was found. He had stents deployed to the different areas, and this was ECG at presentation, and this was the ECG afterwards. I hope you can see the difference. This is the ECG at presentation, and this is the ECG afterwards. Now you can see the ECG afterwards. Very, very markedly different. The SA has come down, and typically when we do, the patient can go home next day or 2 days after. We also try and rehabilitate, but the patient must be on those things for life. This is another patient, ulcer-like.
This is the one I was talking about.
Go ahead, sir.
So 40-year-old man that came Christmas Eve, been getting treatment for ulcer, but the pain, the character just changed that day and didn't respond to any of the medication. And by the time he came in, the troponin was almost like ×10 the upper limit of normal.
Wow.
And the ST segment elevation was from V1 to almost V6.
Wow.
And by the time he went to cath lab, he had 100% of occlusion of the mid left anterior descending. So had clot extraction, then the stent was put.
I will try and show you a video of the case. I'll try and show you a video of the case so that we can appreciate what has been done and what can be done here in Nigeria. What can be done here in Nigeria and here in Abuja in cardio care. So let me see, how do I do this? Okay, so I think we can see that. And then so patient came in. This is the same way we do the angio. It goes all the way up, and then we are able to see what is there. 100% occlusion. This is where the coronary artery should have been. You can see the line. That's where it's supposed to have been, but there was no coronary artery showing there. The left anterior descending is a total occlusion. That wire, I say we pass it, and then we can now pass the wire, and so let me just go back a little. Let me slow down this video a little bit. So this was where the artery was supposed to have been. I hope we can see that this artery ought to have come from here. Let me. So let me do it carefully and then show you. So this artery here ought to have come continuous like this, but we can see that it stopped completely here
because of the 100% occlusion.
So 100% occlusion. That was what's happening in this young man, and this is how the artery is supposed to have been coming across all this way, and then we have 100% occlusion. Luckily, the patient was able to get to the cath lab within 1 hour of coming here, and that's what we now had to do. So let me go on to show you what happened next. So that is how it would have been. So we'll continue. So next, we passed that wire, like I said. This was what we call a BMW. BMW is not like the car. It's a balanced middleweight wire that allows us to cross the blockage and pass all the way in that place. And you can see this small black spot here. That's the balloon, a 2.5 mm balloon that we're inflating there to try and review and deflate, inflate and deflate to try and increase the blood supply. Now, after doing that, we can see that there is some blood flow. You can see some black now. The blood flow is showing, but it's not very good because there are lots of blood clots here in this young man's ECG. So what do we do next? If you look carefully at this one, we have a special catheter called a clot and export advance. It's a special kind of catheter, aspiration catheter. We pass it inside the coronary artery and we suck out the clots. And then we suck out the clots from there. So that is what we call, so we pass this small catheter here and then we suck out the clots. So that's how we went ahead, sucked out the clot, and I will show you the blood clot that we sucked out. See the catheter coming out, and then so can you see the clot that was aspirated from inside? This is very magnified, of course. It's not as big as this. It was magnified very significantly. So you can now see the clot that was brought out. So by the time we did that, after bringing this out, happily, very, by the time we did that now, we cannot repeat it. Can we now see the artery coming out very well? The artery is much better. We can see it showing all the way. But it is still very tiny. It is not the very best. So the next thing we do is to now put our stents to remove across the area of the blockage. That's the small iron mesh thing. And we put our stents. We are taking you through an advanced procedure. You are right here in cardio care over the internet. And then after that, you can see the place that was blocked. There's some blood supply, but the blood supply is not still going very well. Still very tiny blood flow. It should be bigger than this. So what do we do next? We take another balloon and try and optimize the stent. Then we give through the coronary vessels, right inside, we give nitroglycerin and we give adenosine. So this is a very powerful drug. One of the side effects of adenosine when we give it intracoronary is it can cause a heart block. The patient can just go asystole. So we are aware of that and we are ready to deal with it. And the way we also give the adenosine also allows it to reduce the risk of that. So we gave this for this young man, and you can see the blood flow now. It isn't that lovely. The thing that stopped here 100% here, we can see it going all the way down for this man. Chest pain resolved. In fact, by this time, the man was now sleeping on the table from shouting about his chest pain. So this is something that can be done here. I can thank you very much. I can see some hand claps and emojis. Thank you. And luckily, we also got a national award of excellence from the Nigerian Cardiac Society. This is a national center of excellence in cardiovascular care. We've done over 600 plus successful procedures, not just angios for this kind, like we're talking about chest pain, but pacemakers, ICD, resynchronization therapy, IVC filters, all CDT for pulmonary embolism, all kinds of that. And that is what we have been doing right here in Abuja. I would love to share with you and to see whether you can benefit from our experience here in this regard. Okay, so with this, we'll take questions. I think we are more or less stopped. We'll take questions as we try and sort it out with that. I don't know if there are any questions. You can put them in the chat box. We'll answer them. Beautiful. Okay, you can put them in the Q&A box. So somebody asked, can all MI patients get nitroglycerin, Dr.
We talked about patients where you don't want to give nitrates. We talked about patient that has low blood pressure. So your MI patient is rushed in and the blood pressure is less than 90/60. Please do not give them any form of nitrates, whether under the tongue, whether spray. Patients with low blood pressure, patient that has inferior myocardial infarction, because that affects the right ventricle. They will most likely have right ventricular failure with low blood pressure. So you don't want anything that will further worsen that. Then we talk about people that are taking Viagra, Tadalafil in the last 24 to 48 hours. You don't want to give them nitrates. So you have to be careful. You have to make sure that you ask about this, you check your vital sign and make sure that all these factors are not there before you give the patient the medication. So it is not every patient with myocardial infarction that can take nitroglycerin.
Okay, so I think that's very clear for all of us. Somebody's asking about pediatric patients. While I was saying so he's asking about pediatric patients. That's a consultant. Well, for pediatrics, MI is very, very rare in pediatrics, and most of the chest pain is more likely due to pericarditis and infective conditions. You still have to do an ECG in children, but it's not as mandatory as it is in an adult. We've had some cases where we had very young children having some of this, typically due to coronary ectasias. That is, yes, congenital issues that surrounded their their coronary arteries. So that's something you should know. So for children, you need specialist care. There is no shortcut. We cannot just be thinking about vasodilators or all of that. And about cost and technicalities, honestly, I don't know how we can assist.
So the pediatric cardiologist,
need to come in. So we have a pediatric cardiologist on staff in our children's hospital, and we take care of those cases. It's about titrating all the different things and then making a clear-cut diagnosis and be sure about what is wrong with the guests. So so what other question is there? Please highlight the role of aspirin in primary prevention. Is aspirin not recommended for medication? It's actually not recommended. If aspirin is not recommended, what medication can be used for primary prevention? So it depends on your ASCVD score. If you are on this call, you should already have Medscape, Medcal, MD count on your computer, on your phone, where you should be able to check what the score is. If the patient does not have a significant risk for MI or for cardiovascular disease, there is no need for aspirin. There is no need for aspirin. So the aspirin is reserved for those that have a significant risk. They have diabetes. They have a significant risk for atherosclerotic cardiovascular disease. So those are the ones that we give. So it's not necessarily all patients. So you should be careful also giving patients that don't have very high risk, patients that are above 65, because you end up with bleeding and all of that, and that can be very significant.
Okay. And in the context of our discussion of today, for patients coming in acutely with this pain, you need to give them that 300 milligram. Yeah. And after intervention, especially for those that we abstain, they need to be on 75 milligram of aspirin. Dual antiplatelet. Here we use aspirin and clopidogrel for at least
6 to 9 months.
6 to 9 months as the case may
So if you have seen a patient, maybe we have stented your patient and we send back to you. Please don't tell them that we made a mistake by giving both aspirin and clopidogrel. We did not make a mistake. The patient needs to be on those two drugs to prevent clots, clots in that stent. They have to be on it for 6 to 9 months. Now, if they have to do a surgery or something, please call us so that we can give advice in that regard. How to stop, what to do. They have to do a surgery because it's typically not good to do surgery while you're on clopidogrel, and then you can take it off. So we'll give advice in that regard. But typically they need to be on dual antiplatelet for at least 6 to 9 months if they had a stent in, and they typically need to be on either one of them for life. So typically clopidogrel preferred has to be on it for life. So that is typically okay. So let me see. Can isosapine be used if the person is not available? Yes, but isosapine is typically oral and not long acting. So it does not give the effect immediately. So when you give it, it will slowly. Just take time and stock your clinic. These drugs are available in this country. So take time. But if you don't have nitroglycerin, you can use isosapine. It's a little long acting. So when you give it, it will take some time to work and have the good effect in that regard. Please, does cardiac care have drug, electric stent, or bare metal stent? So generally, in modern practice, almost there are indications for bare metal stents. They are very few. So virtually all our stents, 99.9% of our stents are drug electric stents. We have loads of stents in our cath lab, different sizes, shapes, for the leg, for the hand, for different kind of things, so that any kind of patient that comes with whatever problem, we can sort it out. So shed some light on vasospastic angina. Shed some light on vasospastic angina.
Means metal angina.
Yes.
So what we have here is there is spasm, or let me use the word contraction of the coronary artery. This is common in young people.
Yeah.
In young people who present with typical chest pain.
Yeah.
But you go in, you don't find any atherosclerotic changes. So that is why we say it is not only atherosclerotic occlusion that can cause MI. So you can have some spasm of the coronary artery giving rise to that cessation of blood flow. So it happens and patient gets better, you do your angio, the blood and the coronary vessels are clean. So these patients, like I said, they are typically young, there will be history of illicit drug use, and you will typically need to give them some calcium channel blocker to relax the coronary blood vessels.
Vasospasm is typically vasospasm, and typically we don't put a stent. We just give drugs and treat it. Somebody says, could elderly patients with acute MI have these PCI procedures? That's Dr. Atkins, family physician. Yes. In fact, that's whether they are 90, whether they are 100, whether they are 105, we can do it. And you know, it is just the arterial puncture that we are doing. And the patient is awake. It's not like I'm giving anesthesia. So it is extremely safe even for those ages. Yes, there might be some slightly added risk, but the risk is still less than 2% risk of complications. So this is quite important. Somebody says in rural and resource-poor settings, what are the first aid for MI? There is no different treatment for people that are poor and people that are rich. The same treatment in rural areas and poor settings is the same treatment in places that are wealthy. The only difference in this case may be that rural and people may not have access to a cath lab or to have stents. So, and they may not have access to the better clot busters. So they may have to use streptokinase, but still they will still have to spend some money. They will still have to get aspirin, clopidogrel, statins, nitrates, bisoprolol. All of those things still cost money, and those things are life-saving. So they should not die. We are still engaging, even as cardiac care, we're engaging with the National Health Insurance Agency and other agencies to see how insurance coverage can be extended to reach different parts of the country, and we hope that sooner rather than later that will be available for others. All right. Somebody asked, why don't you give nitrates to people with inferior MI? The reason is because of hypotension. The blood pressure could go down very significantly, and you may not be able to get it back up. So it can be very, very serious. So we typically have to be careful in that case. Can you use, as somebody answered that? Can you care drug-eluting stent? Yes, we use drug-eluting stent for everybody. The WhatsApp group, if you look in the chat box, Pamela, if you look in the chat box, you will see a link that you can use to join the WhatsApp group so that you can ask your questions even after this, so that you can do. Somebody said, will the CME point be shared? Yes, the recorded presentation. Go to our YouTube page, not just this presentation, other pages are there, other discussions are there. So this presentation will be right there on our YouTube page. The link is in the chat group. You can go to YouTube and you can see this recorded presentation and other ones that will be there. So that will be really helpful to your practice going forward. What is the role of nicorandil and Vastaril in severe chest pain? Okay, fine. Nicorandil is quite useful, and we typically use nicorandil after coronary intervention. Vastaril, however, is a second-line agent. We typically, yes, like add-on therapy. So Vastaril is an add-on therapy after this one. Patient is still having chest pain despite you have maximized other care. Vastaril. Nicorandil is quite particularly useful in patients that have had intervention. You can use it in the case of nitrates really, but it's particularly useful post-intervention in terms of vasodilatation. But there's a good comparison. There are studies that compare both.
The other notable side effects from other nitrates is less
headache.
It's less with nicorandil. Vastaril is more like relaxation of the coronary artery muscle, so that there could still be good blood flow. But they are just like add-on, not.
It's add-on. In fact, Vastaril does not even affect blood flow. It affects ADP or something like that. So it's just an add-on and just improves pain. Somebody asked, what do we use to preload our patients for PCI? That person is a very serious person. Anybody that asked that person is a very, very serious person. Let me see the name. I can't see the name very well. Okay. Somebody said, what do we use to preload it? So for preloading, we typically use, and we use heparin afterwards. Please, sir, what's the best position for MI patients on referral to the higher center? The position that is comfortable for the patient, but typically we live in cardiac position. So, what's the question again? Preload. So typically we do 600 milligrams of clopidogrel and 300 milligrams of aspirin. Or we use 180 milligrams of ticagrelor and 300 milligrams of aspirin. Whether use ticagrelor or clopidogrel. That's what's available in Nigeria currently, readily available. Ticagrelor has a relatively faster onset of action. So if you have an active patient like that and you are trying to do, try to see what it is, that's what we do. We just go to ticagrelor, get a faster action, and then you go in. Then, of course, when you want to put a stent, before you take any value on any coronary arteries, we typically must heparinize the patient. Then we measure what we call the activated clotting time, ACT. Throughout the procedure, we measure it, and after the procedure, you have to measure the activated clotting time before you remove your sheet, that the patient does not bleed. All of those things, we follow them according to international guidelines, and we've had very fantastic successes, results by doing what is the international standard. Okay, for unstable angina, how do you manage? You manage medically. We manage medically on the ward. All the medical therapy monarchs, we follow everything.
Same for everything.
Everything.
Where you have the difference is in that initial acute management.
Yeah.
But the other treatments is the same. Nitrates, beta blockers, statin, antiplatelets, ARB, ACB inhibitor as indicated, and the treatment of other cardiovascular risk factors. Somebody said,
I manage a patient with BP 140/90. 4 days before it was 180/100. Chest X-ray was normal. ECG showed anteroseptal segment elevation. Patient has no chest pain whatsoever. Again, just like we said, patient has ST elevation, you must do troponins immediately. You must do troponins immediately, and then you follow our algorithm. You follow our algorithm. No chest pain, S elevation, do the troponin. If troponin is high and there's no ongoing chest pain, is this new or old? It could be a silent MI that is happening. Remember that a significant to 20-30% of patients do not have chest pain despite having MI. So that time they came, they say 4 days ago, it came with 180-100, and now it's 140-90. That 180-100, that time they came, likely they had the MI. So they came to a silent MI, and you need to manage accordingly. Get the patient to a cath lab, get the patient to a specialist as soon as possible. Even now that you have seen this presentation, get the patient to a specialist as soon as possible so that he can plan. So in MI, we give 300 milligrams of aspirin and 300 milligrams of clopidogrel. Yes, typically 300 aspirin, 300 clopidogrel, but be sure of the diagnosis before you do that. And then thereafter, we now continue at 75. Okay, review medications 65 years old, hypertension, obese, all one daily. I don't understand the question. What are the contraindications and complications that can arise from this procedure? Yes, there are contraindications and there are complications. Complications can be many. However, complications are typically less than 0.5, less than 1%. So 99% of cases worldwide, including cardiac care, do not have any significant complications. But they could bleed from their side. All the aspirin we are giving to clopidogrel, they could bleed. Heparin we are giving, they could have arrhythmia. Sometimes when you open the blood flow back to the place that was blocked, they could have what we call reperfusion injury. That blood that comes suddenly, that place gets excited and it starts giving abnormal rhythms. So that abnormal rhythms, join the WhatsApp group by clicking. Pamela, I think you added it in inside Q&A instead of chat group. Where's Pamela? Please put it in the chat group, not in Q&A. They might not see the Q&A. So those are these. Now, some contraindications. If the patient is coming too late after the chest pain and the patient is stable, we typically will not go in. If the patient has very significant renal dysfunction, we have to be careful. But remember, this is a life-saving condition. So every case is taken differently, case by case basis. If the patient declines to give consent, it's a contraindication. They say that they are afraid, they don't want to do, they want to pray, we allow them to pray, and we too will pray with them. Okay? So somebody says it's clopidogrel better than clopidogrel. It is theoretically better than clopidogrel, but it has a side effect of dyspnea in some patients. But it has better antiplatelet activity and it has faster activity from time of taking it. So yes, but if it's available, yes, typically better. Yes, typically better. You see it.
But we should also know that the risk of bleeding or other complications from them is also higher than clopidogrel.
Okay, so if you want to refer to cardio care, 0908 331 7777 is the number that you will use. I'm very grateful. We had over 260, 270 participants from all over the country. We are very grateful to all of you. I'm sure you had value for your time. We will send the link across, but if you look in your chat box now, you will see the YouTube link to our channel, so that on our YouTube, please click subscribe, follow, so that you can look at all our, and when we post it, you will get the notification. Also click the notification icon so that you will know whenever we post a new video again, so that you can watch and benefit in case you even miss the group. And you want to watch it again, go back to the YouTube channel. Okay, there. There's also a link in the chat box to join the WhatsApp group so that you can discuss cases. You can put your ECGs if you need assistance. But remember that it's not an emergency group, so so that is the case. So we are here in Abuja by the grace of God. I want to thank all of those, including our learned colleagues. The link is here in the chat, but just scroll up in the chat group, and you will see the link for that. Or if you can't find that, go to cardiocare.ng/webinars. Go to our website, cardiocare.ng. You also find the links there. The recorded presentation and your CME points will be sent to your mail. I want to thank Dr. Alekon especially for the fantastic presentation. I want to thank Pamela. I want to thank everybody. I want to thank all of you for joining up. We are truly, truly, truly grateful. And then if there's any burning question, we will just take it. But however, thank you all from cardio care to the world, from Abuja to the world. So please do good by referring guests that need it. That does need not only this, that if patient has diabetes and diabetic foods, let's try and save that lane. Patient is a pacemaker, patient is a device, and occasionally we do have some charity that is available from donors and from the hospital. We give about 10% of all our procedures as charity. So occasionally we can help in one way or the other when issues arise. So with this, without much ado, we will close this.
We'll be back next month.
Yes, so next month, by God's grace, we will be back. If people that want to join the cardio care group, please look in that chat box here. You will see the link to join the WhatsApp group. Okay, you will see the link to join the WhatsApp. We will also send the link to your email when we are sending the slides. We will send the link to join the WhatsApp group so that you can also contribute, and you will get notification of our next webinar. Before cardio care next webinar, our children are going to have a webinar on meningitis in children. Fantastic webinar coming up. Our pediatric neurologist is doing press up, ready to move stuff in that regard. Please go through the link. Is there. The link is there. Just go up in the chat box. You'll see the link. Or otherwise, just wait for the mail. You will get the mail. I want to thank you all for joining us. God bless you. And we wish everyone good health and fantastic weekend. If you're in Abuja, please join us tomorrow for Abuja Health Walk. We'll be walking from Limi Hospital Central area at 7 a.m. We'll also be teaching CPR. So if you're in Abuja, join us. Let us practice what we preach. Join us tomorrow. All right, bye.